Does your asymptomatic patient really need a mammogram? The American College of Obstetricians and Gynecologists, that is ACOG, recommends screening for breast cancer, i.e., self-exam, clinical exam, radiologic exams by mammography, for women without a prior IBC, that is invasive breast cancer diagnosis. Is screening worth it? That is our whole question that we're asking here. For women without a prior diagnosis, there are three perspectives to consider. Does early detection actually save lives? What are the harms of mammograms? And what are the 7 behavioral practices to reduce IBC incidence? Well, we begin with how much cancer is there really to be found among these women? Any screening should be proportional to the prevalence of that disease within the interested population. A striking new meta-analysis of 2.4 million women is what's new here, and is good news for pre- and postmenopausal women who never had a diagnosis of invasive breast cancer. 94% of these women who had no prior diagnosis when they were enrolled in the study would remain cancer-free over their next 25 years. The graph arrays that data in a timeline from the beginning of the study, the duration on the x-axis, all the way out to 25 years. And you notice in the early years, close to 99% remain cancer-free, and by 25 years, it is about 95%. Does mammogram screening save lives? We answer that question in 2 dimensions, in terms of total lives lost and in terms of breast cancer cases. In terms of total lives lost, screening does not actually save lives, well documented. Screening has not reduced total mortality, and total mortality from breast cancer has been less than 1.2% regardless of screening. Now, in terms of breast cancer cases, long-term follow-up showed no mortality benefit of repeated screening of women. But short-term studies, inflated by overdiagnosis, appear to reduce mortality. So let's address that. Overdiagnosis and the illusion that screening reduces mortality rate. First, a definition. Overdiagnosis is the diagnosis of a medical condition that would never have caused any symptoms or problems. This kind of diagnosis can be harmful if it leads to psychological stress and unnecessary treatment. The link to this particular definition is at nih.gov. Widespread screening of asymptomatic women produces overdiagnosis, swelling the number of cases by 30 to 50%. This depends on which form of screening is done. When we added tomosynthesis, it approached 50%. Now let's go to case mortality rate. That also is a definition. It's a calculation, the number of women who died divided by the number of cases of IBC. The number of deaths in an enlarged pool that includes 50% overdiagnosed cases lowers, and I put quotes around lowers, the case mortality rate by 50%. Conclusion: overdiagnosis can create a reason to incorrectly justify mammograms. But this justification is a chimera, promoting more screening, yielding further illusory benefit. I invite you to pause the video and take a close look at this slide. It provides a hypothetical example comparing 2 institutions, one with overdiagnosis and one without. Ironically, this practice of overdiagnosis is what creates the illusion that mammograms save lives. So with the growing recognition that overdiagnosis falsely implies a reduction in case mortality rate, it's appropriate to look at the harms of mammogram screenings. And there are 10. The first we've discussed, overdiagnosis, which is now approaching 50% of the cases found. The second is substantial false positive rate. The third is overtreatment with toxic effects of surgery, radiation, chemo, or hormone therapies. The fourth, radiation itself increases breast cancer. For every 100,000 mammogram screens, 125 new cases of breast cancer emerge. And digital tomosynthesis doubles this rate, and it's cumulative with each increasing year of mammography to a patient. Then there is loss of income for the patient, the time away from work. Chronic psychological and physical distress has been well documented to persist for years after a biopsy, even when the results are good. Substantial side effects are common. Treatment costs. By 2012, over $4 billion a year was being spent by the insurance industry to support false positives, overdiagnosis, and overtreatment. And those were at the rate of a 23% overdiagnosis, not the 50% we're approaching. The ninth is conflict of interest and rarely disclosed. Perhaps you know physicians who, when they recommend a mammogram at their institution, receive a check in the mail, a thank you for a referral fee. And 10, the failure to warn. Informed consent that is incomplete and not understandable is not an informed consent. And lacking all 9 of these issues reviewed with the patient and the doctor, there cannot be an understandable informed consent. Finally, the 7 behavioral practices that increase freedom from breast cancer and reduce mortality are an appropriate conversation between the physician and the patient. First, prevent weight gain, then exercise daily, then enjoy wine in moderation, get daily sunshine, prevent the plunging progesterone and estrogen levels characteristic of peri and postmenopause that trigger the increased incidence of breast cancer. Learn about and engage in the best individualized options. Discover the demonstrated benefits of sequential bioidentical hormone therapies and the dangers of continuous combined and/or synthetic forms of menopausal hormone therapy. And finally, if asymptomatic, refuse mammogram screening. Instead, submit to professional breast exams from an experienced healthcare provider when appropriate. The benefits of mammography lessen and the costs and risks increase when we find evidence of less risk of invasive breast cancer, as in our new study of 2.4 million women. For those patients who have no prior diagnosis, this is very good news.